Okay, so I think this is number 3 from Stockwood. And yeah, so as I said, I just took some of these slides out. So some of them are from talks that we used to do as a peer review group, which I thoroughly recommend. And what was interesting about this is that one of the people who presented, whose research this was, I knew. And, we had a problem or a potential problem with Legionnaires. And so, of course, we now have new guidance on Legionnaires. And if you're in a practice, you have to pay someone to come in and check for Legionnaires. And it's like one of these many things and I'm not 100% sure how likely these things are to be a problem, in that the people that this affects are just people who are so unhealthy, they can't get to see you. So anyway, we kept having our water checked and adjusted so that the likelihood of Legionnaires was extremely low. And the advantage of Sterilux is that unlike hypochlorite, it's kind of got a half-life that's a lot shorter. I'm not sure, is it 12 hours or something like that? And so it's hypochlorous acid. It says there superoxidized water. I think that might be the same thing. But basically, it was good for our water lines. You could then use it for it was very green, really. So you could use it to wipe down the work surfaces and things like that. The thing I used to really like it for was flushing out the canals. After it used hypochlorite, I'd use Sterilux, but with the view that then there'd be less likely to be, any bugs that could have been down the canal that the hypochlorite was going to get at would have been removed. And the last thing you want is just the hypochlorite, which will hang around forever, causing issues. So that was my logic. And obviously you dried it, and as long as you got the canal dry, I'm having fun here. Yeah, as you got the canal dry, then I would fill it. So I'd normally do them in one visit. So the thing about hypochlorite was we all use rubber dam. Right, my view is that we use rubber dam because we were worried about dropping hand files. Well, as mentioned it before, because of CJD, we ended up having, rotary instruments. And so you're not going to drop anything if it's in a rotary instrument. You just got to make sure that it's actually attached to the instrument. And how much hypochlorite are you allowed to put in the mouth? Well, quite a lot, really. If you look here, you certainly don't need to be using a syringe full of hypochlorite. You only need enough to go in the canal. And that amount in the canal, when it's rinsed out, or rinsed out with hypochlorite, and you still would do it so you didn't fill the pulp chamber. You just need to fill the pulp canal and a tiny little bit on the pulp chamber. So this is kind of nonsense, really. In my view, lots of patients don't like having the rubber dam. Once you've gone through all the effort of fitting them, that has a cost element to it. So most people I know of my age were quite happy doing root fillings, albeit without the, I think we used to call it a parachute. Now that was nervous, and they were slippy, but now it's so much easier to do root fillings. And yeah, it says there, the conclusion is sodium hypochlorite mouthwash is effective as chlorhexidine for treating gingiva, but that's marketing. So I like this. And so, yeah, and I think these are very good for cleaning around implants. That's right. So that's why I have them. That's why I have them. And so I think the results are pretty good. As we know, in the long, take the long term to find out, because you're talking to someone who bought a Cavimed thinking that was going to cause everything. I mean, prior to that, we used to cut, gingivectomies, simple gingivectomies. God, that was a lot of bleeding then. But anyway, fortunately, we've stopped doing all that. And now we realize that the Corsetil was only a transient effect. This may be better. We'll look at the long-term results, but it might be in 20 years' time we're saying they don't work. But my gut feeling is they probably do. Right, that's right. So clearly I've used my airflow. I like that. That was really good for lots of things. And generally the patients like it. A little bit messy. Whenever I said to my nurse, to Denise, let's get out the airflow, you could see her look at me twice because you get powder everywhere. But what I used to do was, if someone had Perry and was keen, then I would do what you commonly know we can't call a scale and polish. So I never really did a scale and polish, but I used to obviously use my ultrasonic. I was terrible at hand scaling, as are most people, and we now know it's not necessary. The only time reports came out saying that it was as good as using the hand scaling was as good as using an ultrasonic was during COVID. And that's when you start to look at the research you want to see. But anyway, if someone was on a plan and they had perio, then what I tended to do is I'd rotate them once they were stable with the hygienist. So this is the patient. I know, this is the patient who caused me to do all these blinking videos. It's because I sent her a video on pocket cleaning, and it must have been after this because I'd made her a chrome, and the premolar it was hanging off had got loose, so it's a little bit after this, and yeah, so I thought that's bye-bye. Then I went on a course for perio courses on perio, and they showed the video of pocket charting, which I could download, which I did and passed on to her. And she came back a few months later and everything was fine. You thought, hallelujah, now that's interesting. You send someone a video showing them what to do, and they listen to the video. This woman was in her mid-70s. She watched it on her iPad, and then everything got better. Oh, well, that's teledentistry, isn't it? So anyway, and the other thing I used to say was that if I use the ultrasonic and scale someone's teeth with the ultrasonic, there was no bleeding, then I often thought I shouldn't really charge them. Oops. And what's that one? Oh, this is yeah, so that's it. This is, yeah, Shirley. That's when I sent the YouTube channel. So that was 2018. And after that, in 2019, I'd developed my app and I'd send the BPE. Did it say? Yeah. Yeah, the BPE perio. That was what I put down, and I'd send them an email with the BPE on to encourage them to check themselves and with videos on how to improve it. So this is just to show what X-rays were like. And now we've gone digital. You know, I thought when they brought out these templates, you thought fantastic, because getting them out the little paper cartons, that was hard work. And yeah. And now we've got this. So you can manipulate these in all manner of ways. But they're, you know, it's so much better. What's interesting now, I don't think this is going to show, but these could be used historically. If we, you know, it's just data. And, you know, if you look closely, I guess, I can't even see the patient's name, which you shouldn't. But it's data, you know. So we've got a history of these, so we can see what's progressed and what hasn't. So we know the AI, yeah, we know the AI can look at these radiographs far better than we can. So, you know, when I say look at them, it can interpret them, because our eyesight isn't that good. And so we can go through these and decide what, you know, what we should be doing and treat disease, as opposed to, we know, which is what most people want, really. And not, when I say treat disease, identify disease. So at the moment, we can use these to augment, but all the research shows that the later versions, and with machine learning, we know that these are going to get better, that we'll be reliant on these a lot more than our own sort of interpretation. Obviously, you need to take into account the hygiene and lots of other things, but in the main, using AI for these is going to be good. Showing your patients the radiographs, yeah, that's the way forward. And also showing them pictures with your intraoral camera. The daft thing is that let's see what the next picture shows. Yeah, the daft thing is you can show anyone a picture and say, oh, that doesn't look good, that needs doing now. This amalgam doesn't look great. You can even see the pin poking through. And I remember this chap because he'd been seeing me when we had the problem in 2006. I knew I was going to struggle because I kept looking at my patients in the eye and doing what you shouldn't do is drop the price. So I tried to get them all on the plan. So this chap had been on a plan, and he said, I just haven't had any treatment, you know, but I'd make sure everyone went to see the hygienist who was on the plan. And of course, they didn't need treatment. The material didn't fail as quickly, for sure, because they were looking after it. Never, you're not going to get secondary caries. So this was, this is the same chap. The interesting part here is you can see he's got tiny amalgams. And I remember, now like it would be 1985, 86. I met a dentist who had trained me really when I was a student in Cardiff. And he was saying it's terrible the way these people have made money doing these tiny occlusal amalgams, because you'd make money from doing a small amalgam as a big one. And I thought, that's dreadful, that's dreadful. And now you think, do you know what? They didn't have sealants back then when these were done. And even when these fall out, the guy's going to keep it clean. So often you'll see people with like smooth holes in their teeth, but they keep clean with their electric brush. And they, once upon a time, some kind dentist cleaned out the fissure and just probably put a bit of amalgam in with their thumb, and they've lasted extremely well. So yeah, what's this saying? Yeah, so keeping the crown margins at the gingival level as opposed to below. Going below that was always easy because the patient couldn't see it, but putting it just at the gingival margin was what I always tried to do. But if you had a polycarbonate slit cement, which was white, it didn't look great. So when they brought out glass ionomer, they said, well, you can't use it for crowns. I think it was Aquacem was the first one. I thought, well, I'm going to do it anyway. And of course, everyone uses glass ionomer now. And and it's they work fantastic. And yeah, you don't get secondary decay. So I think that's what meant to be showing, and just showing that these old amalgam fillings, they last forever. I think I spoke elsewhere about the first composites that we did were self-cured, and they were, of course, no end of trouble, which is why I never really got to be great at them, which is why I like doing these large composites. So I used to do a glass ionomer. I tried doing sandwich ones. They weren't great. So yeah, top up the glass ionomer or do a ceric, as I would say. And I don't know what this Ryan means. Yeah. But so the thing on the top left, I bought one of them because I thought for making my app, you could take a picture of people's teeth using this smile light. You put the camera behind, and you get a really good photo of the teeth, and then you can mark on the teeth on the app where to put the TPs. But anyway, I haven't got that far. And like my son said, no one will let you touch their, I think he used a few swear words, Dad. Phone, Dad. Don't touch their bleep, bleep, phone, Dad. And so this is, as you know, so if a patient takes a photo of their own teeth, they've got a record. This one, I think, to be honest, was probably taken with one of mine cameras at work. But I've got cameras at home now that are just better than that, and they cost under £50. We should be using these a lot more and encouraging people to do it. So this was my Diagnodent that I got with my ozone machine, and it was really good in that you're not 100% sure if it was accurate, but it was pretty accurate. And it gives you an indication for yourself and your patients to see if decay was progressing. And so I'd write then, I wouldn't do anything if the reading was 20 or below. If it was 20 and above, it's hard to remember now. I think I'd apply ozone and then I would seal a tooth. If it was 25, I'd open up the fissure and apply ozone and then seal a tooth. Sometimes you'd open up the tooth and the reading got higher, and then you start getting a bit twitchy, but you'd open it up a bit more and a bit more. And if it opens and it's getting higher and higher, I'd stop and put in glass ionomer, especially if they're young, because obviously you're not using local for this. Yeah, and go back there at a later date. But putting in glass ionomer, I use Fuji Triage or Fuji 7. That was very good. I don't know what the noise and vacuum means. Oh, it makes a noise. Yeah. And yeah, and I when we hear about art, when they brought out the Compomer Direct, I think was the first one. Well, the first one I used. We started using it all the time in children. And it's unlikely it would last the until it would exfoliate, but they lasted pretty well. And these, I used to just put Fuji triage in and carry out, as you would say, art with children anyway. And you just have to be quick with children. And all I know is I never referred any child for a GA that I'd been seeing from when they were a baby. There was one who I nearly did, and that was very sad. Because his adult dentition went the same way, and he'd had some psychological issues, which is sad. But I never referred anyone for a GA. And you think about it, if you give antibiotics for wisdom teeth and we don't have them taken out for 18 months, can't we do the same for kids? Anyway, I shouldn't have said that. This was where it was good with the camera. So this camera, you can see when the photo was taken, and you can see how I was trying to measure it. That's a perio probe for people who haven't recognized it. Yeah, I couldn't get him to heal up after I took the tooth out. And so I referred him to the hospital. Oops. And it was, yeah, you can see it was the upper right four that hadn't healed. And yeah, he was on bisphosphonates. So sadly, he died. And he was a lovely guy. Yeah, and ended up taking out a couple more teeth, which is always a bit of a mare. So it doesn't happen for everyone, but it does happen for quite a few. But I remember sending it down to the dental hospital, and they weren't sure what it was. So this is just talking about what you can do that's different. Yeah, so I did tooth whitening, and it's fantastic. I'm someone who used to replace crowns to put a darker one in because because they stood out like a white beacon in the end. Right, so I'm going to stop there because I think that might be 20 minutes.